Alright, so let's now proceed ahead and discuss regarding the evaluation of a patient with a suspected mitral stenosis. Okay, let's discuss the evaluation part. So in the evaluation, first coming to the ECG changes in mitral stenosis. Now coming to the ECG changes, when you think of a mild mitral stenosis, okay, a mild MS, the ECG is actually a relatively insensitive investigation. Okay, for a mild MS, this is relatively insensitive. Okay, but to have prominent ECG changes, it is most likely going to be a moderate to severe MS. Okay, so for moderate to severe MS, you are going to have ECG changes. Okay. Now, if you have a patient with a significant mitral stenosis and who is in sinus rhythm, you most likely will have an LA enlargement, because definitely the left atrial chamber is likely to be enlarged when the mitral stenosis is significant. So in a patient with a significant MS, and in sinus rhythm, you will have a left atrial enlargement. This is almost seen in about 90% cases. Okay. So 90% cases you are going to have a LA enlargement. Now suppose if it is a long-standing mitral stenosis, especially in long-standing mitral stenosis, there is a likelihood of development of what? Atrial fibrillation. Okay, so that is also one finding that you should look for, whether there is atrial fibrillation. Okay, atrial fibrillation. Next point is, when the patient with a mitral stenosis goes on to have a pulmonary hypertension, the patient can develop a right ventricular hypertrophy, and the ECG will show evidence of RVH and right axis deviation. So a patient with a mitral stenosis and a pulmonary hypertension will have features of RVH and right axis deviation. Okay, right axis deviation. All right, and this often happens when the right ventricular systolic pressure actually increases, and this again is seen with a long-standing mitral stenosis. Okay, the features of LA enlargement, the ECG appearance we have discussed in the ECG module, so you can go back to that where I have discussed what all changes happen. All right, so that is about the ECG changes in case of mitral stenosis. Then let's move ahead and discuss regarding the chest X-ray findings. Okay, the chest X-ray findings. So coming to the chest X-ray findings, well, the radiological findings in case of mitral stenosis is indirectly an indicator of the severity of mitral stenosis. Okay, and what happens is, as an early finding, okay, suppose a patient has developed an MS and early in the disease course, one of the important radiological findings that you can note, okay, which I'll just show you in a X-ray. Yes, so one of the early radiological findings that you can note, as is shown in the arrow here, is a straightening of the upper left border of the cardiac silhouette. Okay, so you can see there is actually a degree of straightening here, okay, which is quite obvious. So that is often an early finding. Okay, this is often an early finding. Okay, early finding. But once there is a hemodynamically significant mitral stenosis that has developed, you are likely to have more of left atrial enlargement. But extreme left atrial enlargement in case of mitral stenosis is quite rare, unless you are having a coexistent mitral regurgitation. Okay, so chest X-ray in case of mitral stenosis in the early stages. What is the radiological finding that develops? Straightening of upper left heart border. Okay, and once the patient goes on to develop hemodynamically significant MS, you will have LA enlargement. Okay, more prominent LA enlargement. But again, I told you, extreme LA enlargement, it is less likely, okay, unless there is a coexistent MR. Unless there is a coexistent mitral regurgitation. Okay, very clear. So, what are the other radiological findings associated with mitral stenosis? The other radiological findings include, one is the prominence of main pulmonary artery. Okay, prominence of main pulmonary artery. All right, important. Next point is, you will have something that is known as cephalization of the pulmonary veins, which means the dilatation, okay, the dilatation of the upper lobe pulmonary veins, okay, dilatation of upper lobe pulmonary veins. And what is that term? It is cephalization. Cephalization of the pulmonary vasculature. Okay, cephalization of the pulmonary vasculature. And also, as the disease progresses, when there is more of LA enlargement, there can be a posterior displacement of the esophagus by the enlarged left atrium. Okay, there can be a posterior displacement of esophagus by enlarged left atrium. Okay, so these are also some important findings that you should know. Now, next in mitral stenosis, it is also very important to know the reflection of interstitial edema. Okay, so let's learn about the curly lines. Okay, the curly lines. So, curly lines, basically what are these curly lines? They are thickened interlobular septa. Okay, what are curly lines? They are thickened interlobular septa. Okay, thickened interlobular septa. And see, there are curly A lines, curly B lines, curly C lines. Let's see them. Well, in case of mitral stenosis, when the patient goes on to develop interstitial edema, the patient first can have development of curly B lines. Okay, curly B lines. And what are these curly B lines? Well, curly B lines are actually short lines, short horizontal lines. Okay, what are these curly B lines? They are short horizontal lines. Okay, it's very important to know about curly B lines. Okay, and most often these curly B lines are actually seen at the costophrenic angles. Okay, which are most often seen at the costophrenic angles. Okay, and they are actually prominent in the lower and mid lung fields. Okay, they are prominent in lower and the middle lung fields. Okay, prominent in the lower and middle lung fields. And to have a development of a curly B line, most often the resting mean left atrial pressure, okay, the resting mean LA pressure Okay, it's at least 20 millimeter mercury to have the development of curly B lines. Okay, so I hope you are clear regarding what is a curly B line. We'll come to the X-ray very soon, but I hope the idea is actually clear. Okay, now again, what happens is when the disease progresses, when the patient goes on to have a severe and a long-standing MS, okay, severe long-standing mitral stenosis, then what can happen is that there can be curly A lines. Okay, curly A lines. So curly A lines are again straight lines, can be approximately about 4 centimeter in length. Important thing of this curly A lines is that they are running from the periphery towards the hilum. Okay, so they are actually straight dense lines, almost say around 4 centimeter, it can be up to 4 centimeter. That important point is they actually run towards the hilum. Okay, run towards the hilum. So that is curly A lines. And we are just left with curly C lines. Okay, curly C lines. So curly C lines are reticular opacities at the lung base. Okay, they are reticular opacities at the lung base, and in fact they are representing the the end on view of the curly B lines. Okay, so they represent end on view of curly B lines. Okay, that is about curly C lines. Okay, I hope this is very clear. We'll come to the X-ray very soon. Now a patient with a severe mitral stenosis, okay, patient with a severe mitral stenosis with a pulmonary hypertension, okay, severe MS with pulmonary hypertension, you are definitely going to have an enlargement of the pulmonary artery, okay, enlargement of pulmonary artery, okay, yes, and you are going to have, as the disease progresses, you are going to have an RV enlargement. And if you have the cardiomegaly in case of mitral stenosis, again the RV enlargement also contributes. Okay, so as the disease progresses, the right side of the heart is also enlarging, the right ventricle is enlarging, and extreme cases you can even have a RA enlargement, right atrial enlargement. Okay, you can even have a enlargement. All right, now next is a very interesting and important sign, but before that, let me just show you regarding the curly lines. Okay, all right, so whatever you are seeing as the arrowheads here, okay, these lines, okay, so whatever you are seeing as the arrowheads here, these are the curly B lines. Okay, these are the curly B lines, whereas these lines that you see here with these arrows, they are the curly A lines which run towards the hilum, and in the base, whatever is shown as the arrowheads, they are actually pointing to, you can see these lines, this is actually the curly C lines. Okay, so curly A, curly B, curly C. Okay, and curly B is actually very important. Okay, all right. Now another important radiological finding in case of a mitral stenosis is what is known as the double density sign. Okay, double density sign, which is also referred to as a double atria sign. Okay, which is also referred to as a double atria sign. So what is this? See, when there is a left atrium that is going to be enlarged, the right side of the enlarged left atrium, this can actually push into the adjacent lung, which actually creates an additional contour superimposed on the right heart. Okay, So that superimposition, you look at this X-ray and you find this arrow, you can see that there is, can you see this? Okay, and also can you see this? Yes. So what happens is that there is an enlargement of the right side of the enlarged left atrium, which is pushing into the lung, and in addition to the orange one is actually showing the border of the right heart. So the in addition to that, you can have an additional contour that is being superimposed. Okay, so just have a look once again. Are you able to appreciate this double contour sign here? Okay, or the double atria sign or the double density sign? Okay, I hope that is clear. All right, and it is also showing, the straightening of the left heart border, you can see. And the dotted arrows here is referring to the cephalization of the pulmonary vasculature. Okay, the upper lobe veins are actually more prominent. All right, and another point about the radiological finding in mitral stenosis is that as the disease progresses, you can have an elevation of the left main bronchus. Okay, the elevation of left main bronchus, and also a splaying of the carina. Okay, and also a splaying of carina. Okay, so what is this splaying of the carina? It is basically meaning that the angle of the tracheal bifurcation will actually increase, which I think is very obvious here in this image as well. The angle will obviously increase. Okay, angle will obviously increase. So these are again some very, very important radiological findings. Okay, and another radiological finding will be seen in the lateral. This is a lateral radiograph, and this is obviously after a radio opaque contrast. Okay, after a radio opaque contrast. What is very, very striking here is that the lower part of the esophagus that is shown in the arrow, there is a compression of the lower esophagus by the enlarged left atrium. Okay, so there is a compression of lower esophagus by the enlarged left atrium. Okay, so that is also important radiological finding. So I hope the radiological findings of mitral stenosis, you are very thorough with that. This is again very, very important. Okay, often in exams they do ask questions based on the radiological findings in mitral stenosis. Let's move ahead and discuss regarding, we have seen ECG, we have seen chest X-ray. Let's now see echocardiography, the role of echocardiography in mitral stenosis. The role of echocardiography. Okay. So echocardiography in mitral stenosis is again a very good approach, to diagnose and evaluate a patient with a suspected mitral stenosis. So what are the scenarios in which you will go for echo? So all patients in whom you are suspecting MS, suppose you are suspecting a mitral stenosis, at presentation you will definitely require an echo to confirm it. Okay. Now suppose the patient has already been diagnosed with a mitral stenosis. Now he goes on to develop, say, new symptoms. He can develop features of right-sided heart failure as the disease progresses. So as a part of the re-evaluation, okay, so re-evaluation, when the patient actually has new symptoms and signs, okay, new symptoms and signs, he will require an echo. That is also very obvious. And also to monitor the disease progression, okay, to monitor the disease progression also, there is a role for echo. To monitor the disease progression also, you will have a role for the echo. Okay. So you can go for a transthoracic echo. Okay, you can go for a transthoracic echo with a color flow and spectral Doppler. Okay, with color flow and spectral Doppler. So let's see what are the, what is the utility of doing such an investigation. So the role is, one is they can identify the transvalvular pressure gradients. Okay, they can identify the transvalvular pressure gradients, that is one utility. You can identify the chamber dimensions, whether there is enlargement of the LA, RV, like that. So you can identify the chamber dimensions. Okay, and what is the mitral inflow velocity? Because once you have the flow Doppler also, you can identify the mitral inflow velocity during the diastolic filling. Okay, the mitral inflow velocity during diastolic filling. Okay, and I told you the patient can go on to develop additional valvular lesions. So whether there is any associated MR, okay, whether there is any associated mitral regurgitation, you can do an echo and find out. Okay, if the MR is actually prominent, you will definitely have clinical evidence also. And you can also get an idea regarding the valve architecture. Okay, so what about the valve architecture, whether you have any architectural distortion, is there any leaflet calcification, what about the mobility? So all these points also you can make a comment about. Okay, so you can make a comment about any valvular distortion. Okay, what about any calcification, what about mobility? So all these points you can make a comment of. Okay, so what else? You can also use this to to determine whether a patient is actually anatomically suitable for a percutaneous mitral balloon valvuloplasty. Okay, so you can determine the anatomic suitability for a percutaneous mitral balloon valvuloplasty. Okay, so PMBV, we'll come to that later. So these are some very, very important indications, where you will go for an echo study. But when you compare the TTE, transthoracic echo, with a transesophageal echo, okay, TEE, that is a transesophageal echo. So one point you have got to note is that the transesophageal echo will be providing you a superior image. Okay, so they will be providing you a superior image, and there is one scenario especially where the TEE will be more useful than a transthoracic echo. That is when you are suspecting a LA thrombus. So to rule out the presence of an LA thrombus prior to a procedure like a PMBV, percutaneous mitral balloon valvuloplasty, a transesophageal echo is preferred over a transthoracic echo. Okay, so the echo part is also very, very clear. ECG we have learned, chest X-ray we have learned, and also echo we have learned. Okay, let's proceed, and let's see if at all there is some utility for the cardiac catheterization. So let's see if there is any use for cath studies. Okay, cardiac catheterization. So cardiac catheterization, well, in routine practice, a routine diagnostic cardiac catheterization, is it necessary for evaluation of mitral stenosis? Answer is no. Okay, so routine cardiac catheterization is not necessary. Okay, routinely it is not necessary. Okay, but then what is the utility? Well, it is useful for monitoring before, during and after a percutaneous balloon mitral valvuloplasty. So monitoring purposes prior, during and after a balloon mitral valvuloplasty, this can be useful. Okay, so yes. And the one point you have got to note is that yes, cardiac catheterization can have some role when you are having a discrepancy. Okay, when you are having a discrepancy. What discrepancy? Between the clinical findings and the non-invasive findings that you have done, like ECG, echo, you have done all these studies, X-ray. So if there is a discrepancy between the clinical and non-invasive findings, in that case also you can go for a cardiac catheterization. So basically you can go for say a catheter based measurement of the LA and LV pressures. Okay, so you can go for a catheter based assessment of LA and LV pressures, and it also helps in assessment of the mean transvalvular pressure gradient. Okay, mean transvalvular pressure gradient. Okay, mean transvalvular pressure gradient. Okay, and it will help you in measuring the transmitral volume flow rate. Okay, so measuring transmitral volume flow rate. Okay, transmitral volume flow rate, and also even the valve area. Okay, if you want to make a valve area assessment, again that is also possible. In fact, there is a formula that is known as a Gorlin formula which is going to help you for that. Okay, so it will help you to identify the valve area. Okay, so these are the utilities of cardiac catheterization. I hope that part is very clear. So we have discussed in detail about the evaluation of a patient with a suspected mitral stenosis, and let's see how you are going to manage patients with mitral stenosis. Okay, suppose you have diagnosed, what about management? So management, well, I'll just show you, this is what I'm going to discuss with you, the salient relevant points. That is the 2020 ACC AHA guidelines for the management of patients with valvular heart disease. So whatever is given in Harrison, Harrison came somewhere in 2018. So Harrison actually quotes the 2014 guidelines. Okay, so this is the 2020 ACC AHA guidelines. So the discussion of my points will be based on the latest guidelines. Okay, so let's have a quick go through the important points in this guideline. So before we go to the management proper, a couple of slides which I have taken directly from the guidelines itself. So what does the guideline actually tell us? Okay, so whatever is given on this left side, COR is for the class of recommendation and LOE is for the level of evidence. So what are the recommendations by the guidelines for the diagnostic testing in mitral stenosis? So the guideline says in patients with signs or symptoms of a rheumatic MS, you've got to do a transthoracic echo. Why? To establish the diagnosis, to quantify the hemodynamic severity, to assess the coexistent valvular lesions, and to demonstrate the valve morphology to determine whether the patient is a suitable candidate for a mitral valvuloplasty or a commissurotomy. So this is why you should do a transthoracic echo. And the guideline also says in patients in whom you are considering for PMBC, which is the same as PMBV, transesophageal echo should be considered in certain scenarios, which I have already told you. That is to assess the presence or absence of an LA thrombus and to evaluate the severity of MR. So always to assess the presence of LA thrombus, transesophageal echo is a superior investigation. There is no doubt about it. Okay, all right. So one more slide from this guideline is that see what is the role for exercise testing in patients with rheumatic MS. So in patients with a rheumatic MS and the discrepancy between the non-invasive findings and the clinical symptoms, You can go for an exercise testing with Doppler, or as I told you, a cardiac catheterization, an invasive hemodynamic assessment to evaluate the symptomatic response, exercise capacity, and the response of the mean mitral gradient and pulmonary arterial pressure. So that is the role of invasive hemodynamic assessment in case of a mitral stenosis. Okay, all right. Now you've got to note is for the management purpose. Okay, for the management purpose, mitral stenosis has been divided into various stages. Okay, well, this is again from the American Heart Association. So they have divided into stage A, B, C, D. Okay, this is very, very simple. I'll tell you what are the relevant points that you should know. So this is the definition part. What happens to the valve anatomy, valve hemodynamics, what are the hemodynamic consequences, and what are the symptoms. So first point is, you see here as the stage moves from A to D, you're moving to a more severe stage. So stage A means the patient is at risk of MS, which means there will be a mitral valve doming during the diastole. Okay. At the same time, during the stage A, the valve hemodynamics is relatively normal. The transmitral flow velocity is normal. There is no hemodynamic consequences and the patient is usually asymptomatic. Okay, so that is the stage A. Stage B is progressive mitral stenosis, where the patient can go on to develop pathological changes of mitral stenosis, which we have already learned. Okay, what all are the pathologic changes? But the most important point is this one. In case of stage B, the mitral valve area is above 1.5 centimeter square. Okay, the valve area is above 1.5 centimeter square. Because from stage C onwards, the valve area is less than 1.5 centimeter square, both C and D. Okay, so B is the stage of progressive MS, and C and D are essentially the same, except that D is a symptomatic severe MS, whereas C is an asymptomatic severe MS. So both are severe mitral stenosis. Okay, so in both of them, the valve area will be less than 1.5 centimeter square. But it is often, patients who are in this stage C, once they get some trigger, an infection, pregnancy, thyrotoxicosis, that can push a patient to a decompensated stage or a symptomatic severe MS. Okay, so that is when the patient goes on to have symptoms like exertional dyspnea, decreased exercise tolerance. Okay, so these terms: at risk for MS, progressive MS, asymptomatic severe MS, and symptomatic severe MS. Okay, so these points are very, very clear for you. Okay, and in both stage C and D, the pulmonary arterial systolic pressure is above 30 millimeter mercury. Okay, so these are the stages of mitral stenosis. Okay, just keep in mind this. We'll be coming to this. This is again American Heart Association staging of mitral stenosis. Very clear? Okay. Now first let us discuss regarding the medical management of mitral stenosis. Okay, the medical management. See, what are we trying to achieve by medical management of mitral stenosis, or what are the aims of such a medical management? Number one, it is to prevent recurrent rheumatic fever developing in the patient. Okay, so prevention of recurrent rheumatic fever. Okay, prevention of recurrent rheumatic fever, that is number one. And number two, it is to prevent the complications from developing, and if at all the complications develop, you have got to treat them. So prevent and treat complications of MS, because MS can go on to develop complications like say embolic events. So when you are, putting the patient to medical management, you are actually monitoring the disease progression also, so that if at all an intervention is required, you can do it at the optimal time. Okay. All right. So first of all, in this medical management, let us see the secondary prevention of rheumatic fever. You're trying to prevent the recurrence of rheumatic fever. What are the agents that are recommended by the American Heart Association? You can go for penicillin G, okay, benzathine penicillin G, 1.2 million units intramuscularly every 4 weeks, okay. Then penicillin V, 200 milligram, that is an oral formulation, 200 milligram orally twice daily. Then in patients especially with a penicillin allergy, you can go for sulfadiazine at a dose of 1 gram orally once daily, or the next option is that of a macrolide. So these are the options that you have for secondary prevention of rheumatic fever. Now a question is very, very obvious. How long should you give this prophylaxis? Well, let me just quote to you the duration of secondary prophylaxis by the American Heart Association. So this is what the AHA actually quotes. There are certain different guidelines which actually quote slightly different durations, but let's follow the AHA one. So if it is a patient with a persistent valvular heart disease, that is, patient is had a rheumatic fever and carditis, and there is some residual heart disease also, okay. In such patients with a persistent valvular heart disease, the duration of prophylaxis is 10 years or until the patient becomes 40 years of age, whichever is longer, okay. That is the duration of prophylaxis in patients with a persistent valvular heart disease. Now suppose a patient had a rheumatic fever with carditis, but as of now, they did not have any residual heart disease, okay. So there is no valvular heart disease as of now. There was a rheumatic fever with carditis. So in such patients, you give the prophylaxis for 10 years or until the patient is 21 years of age, whichever is longer, okay. And in patients with rheumatic fever without carditis, the duration of prophylaxis is for 5 years or until the patient becomes 21 years of age, whichever is longer. So this is the duration of the secondary prophylaxis, and what are the options that we have for secondary prophylaxis also I have discussed, okay. So prophylaxis is very, very clear for you, okay. So what you should do for preventing a recurrent rheumatic fever, that part I have discussed. Now what about the complications? Patients with mitral stenosis can go on to develop embolic events. So let's see what are the indications for anticoagulation in MS. Indications for anticoagulation. Okay. So indications for anticoagulation, number 1, atrial fibrillation, okay. Atrial fibrillation, definite indication for anticoagulation. And number 2 is if the patient had any prior embolic event, okay, any prior embolic event. So maybe the patient would have had maybe a paroxysmal atrial fibrillation, okay. So by the time you examined, you did not find any AF. So that individual also requires a long-term anticoagulation. And third is the presence of a LA thrombus, left atrial thrombus, okay. So these are the indications for anticoagulation in case of mitral stenosis, okay. Now when you go for anticoagulation, well, you should actually go for a vitamin K antagonist, okay. So remember, the non-vitamin K oral anticoagulants, they have not been studied in rheumatic MS, which is why you'll go for a warfarin only, not a dabigatran or an apixaban or a rivaroxaban. The non-vitamin K oral anticoagulants, they have not been studied in rheumatic MS, and you will have to go for warfarin, okay. You will have to go for warfarin, okay. Alright, so that makes clear the medical management of mitral stenosis. Now coming to the valvotomy part, mitral valvotomy, okay, mitral valvotomy, mitral valvotomy. So mitral valvotomy, you can either go for a percutaneous mitral balloon valvuloplasty, or you can say valvotomy or commissurotomy. So that is PMBV or PMBC as you can call it. And you can also go for a surgical. Okay, so one is a PMBV, the other one is a surgical valvotomy. Okay, so surgical valvotomy, it can be a closed mitral valvotomy. Okay, a closed mitral valvotomy. It can be a open mitral valvotomy, or you can go for a mitral valve replacement. So these are the surgical options that you have. Okay, so coming to PMBV, percutaneous mitral balloon valvuloplasty. See, what you do is that you will, with a balloon catheter across the mitral valve, you are inflating this balloon catheter, and thereby, you are splitting the commissures. Because in mitral stenosis, there is a commissural fusion. So, you advance a balloon catheter and you inflate it across the valve and you split open the commissures. Okay, so that is PMBV. I'll just show you the technique also. Okay, so what you are seeing now in your figure is the INOUE, INOUE balloon technique. Okay, INOUE balloon technique for the percutaneous mitral balloon valvuloplasty. So here you can see the figure A, B, C, D. I have taken this from Harrison. You can see that in the figure there is a transseptal puncture, okay, that is between the right atrium and left atrium. It is basically an endovascular procedure. So you can gain access by the femoral vein, and then you go for a transseptal rupture, and the guide wire is actually introduced into the LA, and then this is advanced across the the mitral valve, as you can see here, and then subsequently it is inflated and across the mitral valve orifice, and thereby it is actually splitting open the commissures. Okay, so this is how the PMBV is actually performed. Now the question is, what are the indications? What are the indications for a PMBV? Indications for a PMBV. So this is actually indicated in symptomatic patients. Okay, symptomatic patients. So when I say symptomatic patients, means NYHA class 2, 3 or 4. So symptomatic patients with severe rheumatic MS, okay, severe rheumatic MS, that is the stage D, when the mitral valve area is less than 1.5 centimeter square. You remember about the stage D that we have learned? Yes, okay, the classification of the AHA. So symptomatic patients with severe rheumatic MS with a valve area less than 1.5 centimeter square, and also it is very important to understand the patient should have a favorable valve morphology. Favorable valve morphology should be there. So when I say favorable valve morphology, means the valve is actually mobile, the valve leaflets are not very much thickened. Okay, so and there is no significant degree of calcification that has happened in the valve. So this is actually a favorable valve morphology. And another point is that there should be, if at all there is an MR, it should not be a moderate to severe MR. So what is this moderate MR? Well, as per the indications of the American Heart Association, they say that to go for a PMBV, you should have less than moderate MR. Okay, less than moderate MR. So what is this less than moderate MR? You will have a criteria that is known as, you need not know in detail, that is a Cellar's criteria. Okay, Cellar's criteria. So that is a criteria from 0 to 4 plus, 0, 1 plus, 2 plus, 3 plus, 4 plus. So if you have this 2 plus MR, so it should be actually less than moderate. Moderate is actually 2 plus, okay, it is actually 2 plus. So the degree of MR should be less than 2 plus, okay. So that is also important. So less than moderate MR, and also the patient should not have a LA thrombus. So absence of LA thrombus. So who is an ideal candidate for a PMBV? Is a symptomatic patient with a severe rheumatic MS who has a favorable valve morphology, less than moderate MR, and with absence of LA thrombus. So these are the indications of PMBV, very, very, very important. Then what are the indications for surgery? Okay, what are the indications for surgery? Okay, so the indications of a mitral valve surgery, one is if the patient is not a candidate, because we have seen the indication for a PMBV or a PMBC. So not a candidate for a PMBC, okay. And if the individual has already undergone a PMBC and he has failed, okay. So a failed previous PMBC, okay, failed previous PMBC. So in these scenarios, you can go for a mitral valve surgery, which can be a repair, a commissurotomy, or a valve replacement, depending on the indications. I hope this part is also clear. Now just to finish off the topic, I'll just show you this is the flow chart of management of rheumatic MS. This is from the 2020 guidelines. I've directly taken the flow chart. So this is just what we have discussed, and the division is based on severe MS, that is when the valve area is less than 1.5, and progressive MS. That terminology also we have seen when the valve area is more than 1.5. So you are again dividing it whether the patient is symptomatic stage D or the asymptomatic stage, that is the stage C. So you are more likely to go ahead with the procedure, because you see whatever is given in green, this is again class of recommendation 1. Okay, then orange, yellow. So this is class of recommendation 1, then this is 2B, 2A, this is 2B. So the outline, what I want to tell you is, if you have a patient with a symptomatic stage D, there is a better evidence that or a class of recommendation that a PMBC will prove beneficial. Okay, you have got to look, certain parameters, but I am just summarizing the nutshell. But in case of asymptomatic patients, you will go for the procedure only in certain scenarios. It is especially when you are having a pulmonary arterial systolic pressure which is more than 50 millimeter mercury, or new atrial fibrillation. There are certain indications, but again it is the level of or the class of recommendation is not strong as in case of symptomatic stage D. Even in patients with a progressive MS, even if the valve area is more than 1.5 centimeter square, if the patient is having exertional symptoms, maybe hemodynamically significant MS, in such a case, if there is a pliable valve, no clot, and less than 2 plus MR, we have just seen the Cellar's subdivision. So in that case also you can go for it. Okay, so certain scenarios, even the lower stages, that is the stage C and the stage B, also you can go for the percutaneous balloon mitral commissurotomy. And we have already seen the indications for a mitral valve surgery as well. This is the nutshell of what we have learned so far. Okay, so that ends this topic on the management of how to evaluate mitral stenosis, and then subsequently how to manage a case with mitral stenosis. Okay.